All right, so we are week 10. This is our digestion lab. The group next week, we'll do this again on Tuesday, and then Tuesday and Thursday next week are review labs and our last chance to recover and review lymphatics, respiratory, and digestion. And then that week 12, you're gonna have test 3 and lab 2. Okay, so if you're following along in your lab manual, we want to start with the beginning of the alimentary canal, which is going to be our mouth, okay? And so for our buccal cavity, we are going to have the lips are going to be the anterior border. Then you have your tongue as the inferior border, all right? You have the hard and soft palate as the superior border, and then you'll have the 2 arches, and you do need to know which one is the most anterior arch versus which one's the most inferior arch, and the uvula, and then the falces or the open spaces is your posterior border. Okay, for the inside of the mouth, you have to know your 3 types of salivary glands. If you've been reading the news, again, there supposedly is a new organ or new salivary gland they're trying to get pushed in. We are sticking with the 3, so the submandible, the sublingual, and the parotid, okay? You do also need to know the ducts on this. So how do we get the secretions from the parotid, the submandibular, and the sublingual? How do they get into the buccal or the mouth cavity? And in there, okay? Then you also need to know teeth. And those of you that are my dental school people, you're like, yay, finally some teeth, okay? So by numbers, you need to know which ones are the cuspids, the bicuspids, the premolars, the molars, and again, you can call some the canines, cuspids, canines, incisors, those are the terms, okay? And again, when I put this up on the lab, it would be, I would give you like, what's the tooth labeled number 4? So you could tell me number 4 is potentially here versus here. It should be one of your bicuspids or premolars, okay? And then 6, 7, and 8 should be your molars, okay? So expect to do this on the mouth teeth here or on these, okay? On this guy, we do anatomical landmarks and we do histological layering, okay? So landmarks, exposed part, so where it says 17, that is the crown. What is encased in bone, that is the root, okay? Histological layers, the white is the enamel, the yellow is the dentin, and then this is the cavity, okay? A hole in bone is a foramen, so this is going to be that foramen that allows the blood vessels and the nerves to come in and out. Bone connects to bone through a ligament, so that's that periodontal ligament. And every time I hear that, I'm like, ooh, Nemo, remember Nemo, where the seagull comes in and he's like, has he disconnected the periodontal ligament yet? And I'm always like, oh, funny, Nemo even talked about it, right? So that, make sure when you read the question, if it's asking you for a histological layer, you want to think about enamel, dentin, cavity. If it's asking you about what is the exposed part, that's the crown. What's the part encased in bone? That's your root, all right? Apical foramen, and I think that's everything. Oh, and the part where it has flesh, this is your gingiva, your gums, okay? And this is what gets inflamed when someone has gingivitis, right? And again, when you put the little floss, you're trying to disrupt any kind of tartar, any kind of material that's sticking here, and warm, wet material for consumption, a place where bacteria and something would want to grow and propagate and inflame the gingiva. All right, so that's why you're supposed to floss every day. Okay, so expect one station here, one station related to features, one station related to histology. So that's 3 stations. So easily about 9 to 12 questions on the team. All right. And that usually makes my dental people happy. Okay. For the tongue, the part that connects it to the bottom, that's your frenulum. And again, usually people around that frenulum, that's where the duct is, that your salivary glands that are producing from the submandibular and the lingual are going to be secretions. And some people get that pierced. And so they put a little barbell or they put something usually underneath their tongue in that frenulum. And then for some people that have poor tongue mobility, that is part of the reason why that connection is too thick or it's too long and it doesn't give as much freedom of movement. So that is sometimes with oral surgeons, something they have to do is clip that frenulum, okay? So something else to consider there. The rest of the mouth and the cheeks and the gums, we're thinking stratified squamous, non-keratinized, because it's lots of entry points, lots of potential exposure to pathogens. So we want to buff up those barriers. Okay. And again, when you look on this model, you can see same layers, same kind of landmarks for your buccal or your mouth cavity. All right. You got to look at the pictures to see the frenulum. You got to look at the pictures to see the arches and the uvula. Okay. Tongue. Go back to chapter 17 and it'll go through the different types of taste buds and the different types of areas of your tongue. For those of us that want to do speech and language, want to do OTA and potentially swallowing and speech therapy, the tongue is a big part of the mobility. And so that glossopharyngeal nerve, the facial nerve, the trigeminal nerve, all of that's going to be leading into and having a place with control of your lips, your mouth, your tongue, all right, and swallowing. And so that locations of the tongue, dorsal versus posterior, a little bit of that usually comes, sometimes I might ask 1 or 2, kind of like those random tongue questions, right? But you have your papillae, and they are different on different areas of your tongue. And that goes back to, again, chapter 17. You might need to look at that picture of your taste buds to be able to review that material. Okay, the pharynx has not changed. So we are still oral pharynx, nasal pharynx, laryngeal pharynx, and then we get into the esophagus. All right, so our esophagus. All right, so when we swallow, the epiglottis should cover and prevent food, water, and drink from going into the larynx and going through the glottis that the voice, the vocal cords are making and head to the lungs. So it closes it off and everything should start to go through the esophagus. This is the first sphincter, the first place that we have to relax muscle for food to enter, and that's the upper esophageal sphincter. And it's the one that people forget about, but it's the first sphincter in the system, okay? Then we get into the esophagus, and 4 histology layers of the esophagus, all right? This model goes through esophagus, stomach, small intestines, large intestines. And if we look and see, and you guys have them on your tables, there's still multi-layered, so we still see some stratified, non-keratinized epithelial for our innermost layer, okay? Our innermost layer and our histological layers of our alimentary canal, starting at the esophagus all the way to the rectum. The innermost layer is going to be the mucosa. Then there's a connective tissue rich layer between the mucosa and the muscle. That's the submucosa, the muscle rich layer. And usually you're going to see smooth muscle in a circular pattern and then smooth muscle in this longitudinal pattern running up and down. That's going to be your muscularis layer. And then the outside can be one of 2 things. In the esophagus, because we are not in a visceral peritoneum, because we're in the thoracic cavity, it's known as an adventitia. So it's a connective tissue rich, kind of collagen rich holding on to the trachealis muscle, holding on to its landmark so it doesn't, as a tube, kink or collapse or fall as food is swallowed down. Okay. All right. So histology layers, again, you're going to see mucosa. For the esophagus, we have a non-keratinized stratified squamous. Submucosa is going to be a good rich mix of, again, connective tissue, many types of connective tissue that allow capillaries, allow blood vessels to flow. Then we see the muscle, the smooth muscle rich. A little bit of the upper region of the esophagus, there is some voluntary, so maybe some skeletal muscle, because you start swallowing with voluntary control, but then it becomes involuntary once food gets into the esophagus, and then adventition. Okay, now the esophagus ends where the stomach begins, and that end point is known as your lower esophageal sphincter, also known as, because of its location near left lung and diaphragm, this is the cardiac sphincter. Okay, all right. Stomach, it is a J-shaped pouch. We have the lesser curve, the greater curve. We have 4 regions. Draw an imaginary line from where the sphincter would drop food. Anything that would go above in this J-shaped pouch, that's the fundus. The cells in this region, in the deeper regions of these crypts, which are going to make up my gland. Some of those cells are going to be the ones that are going to make hormones that tell if the stomach is super full or super empty. So your brain knows stop eating or eat. So if this area of the stomach ever gets full of food, you really want to tell the brain very strongly, stop eating. Okay, so the fundus is up here. The production of acid, the production of other molecules is not going to be as great in these glands because, again, does food normally end up here? No. Okay. The area right in this region, close to where that apex of the heart could be hitting through the diaphragm, that's the cardiac region. The majority is the body. And then you draw that little imaginary line near the ending part of the stomach, which is the pyloric sphincter. So this is the pyloric region. Okay. Now, you can do histology with this model. This is just the stomach, or we can continue to do it here. Okay, so mucosa, simple columnar cells. The simple columnar cells are going to make hills and valleys. They're going to secrete a little bit of slime. And then as they dip down into these little crypts, to these little kind of pods, some of the cells in here are going to be those different types of G cells, P cells, D cells, chief cells that are going to make secretions that become part of your gastric juice, as well as some of the signaling molecules that go to the small intestines, go to the brain, go to the fat, go to the liver, and communicate as something without the juice, right? The second layer is the submucosal layer. It's not good mix of lots of different tissues. There's a lot of times you're fat in here, right? This is where the lots in the there's a very much action you're moving that kind of organ tissues develop. Then you get muscle. In the stomach, the muscularis layer is going to have 3. Okay, better from here. There's going to be a layer that runs kind of long ways, a layer that runs around, and then there'll be a weak layer. So that allows me to do squish, squish, and then turn. Okay, so I can really get lots of mixing in the stomach. Right, so there's 3 muscle layers in the stomach. This is a lot of layers of the rest. The outside of the stomach, going to be something about here, a little bit of tissue, and then simple squamous epithelium, because this layer is also the visceral perioral epithelium. You're also going to see on this side, right? You got connective tissue, and here's simple rounder tissue, blood cells. That simple squamous epithelium, that covers your visceral peritoneum. Right? Now, think off of the stomach, the stomach stays like above the blood, the fatty acid measure your circle. Okay? We're going to do a little bit more on stomach physiology of the cells are and how they, what they produce, and why they produce, how they regulate energy mixing in the physiology of parts. Okay? But we still need to landmarks of the curves, the regions, the histological layers, right? And the specific tissues are going to be finding that layer of mucosa. Right? Now, the stomach is a stretchable organ. So the wheels and ridges you see here, they can be stretched out, more than stretchable. That's why these are going to do it. Okay? So you do know that one, you find it right here, you got that one, that is stretchable, that is stretchable, that is what you're going to do. All right, so the stomach. All right, now, small intestines again, mucosa, mucosa, muscularis, and most like this a visceral peritoneal limit, serosa. Okay? All right. On this model, right, you see small intestine here. You see that this whole intestine starts, but when it's not intestine, there's a little piece of it that is still connects before it can become so again, when you think about the hands, there's a little piece of over behind that is that first part of the intestine. Or you have broken pancreas, it's a little behind that. This is the visceral peritoneal limit. This is that makes it emerge. And the last thing is I think some water and pancreas is formed. Right? So you can imagine this one stretchable. Right? So this one these are the bones you see, those are not stretchable. Then you get lots of pressure. So again, lots of simple cells and lots of land. And so this time, so you use it with all these glands, they're kind of mechanisms for to allocate to utilize the acid in the cells. Right? And start again, repeating this, let's start taking and then break down to her. Right? So this is you're not using for pushing and the cells are going to be in the glands. And if you have cells, are just because of the enzyme that will break down to. Right? Now, once you get that
everything. Build the organs, these are models. Again, we're going to have this right after. You'll find that we have to, once it comes to the lab, that's only done. We have to see the right? And the little bit of last never report about these things, and the process time. You're going to have monitor and image removal or one of them, right? So we need to go 800 years, right? And one of those layers, 800 years, right? In lecture, that will go through the cell, they're